Welcome to the Deep Dive. If you're a medical student, maybe prepping for your PEDS rotation, or a resident just hitting the cardiology floor.
Or honestly, anyone who just needs a really high-yield, quick shortcut to the essentials of pediatric heart care,
Then this is definitely for you.
absolutely. We know that when you're staring down this mountain of material, what you really need is efficiency. So our mission today is to take those core principles, the non-negotiable facts from the major pediatric cardiology texts, and just sort of organize them.
Into a power course, something actionable.
Right.
We want synthesis here, not just a list of facts.
Exactly.
So we're going to cover everything from the, unique features of the pediatric ECG, how to interpret pressure gradients, all the way through to the most common congenital defects.
And the big acquired diseases that put kids at risk. But, we have to start by setting the context.
Right.
Pediatric cardiology it's fundamentally different from adult practice. We're dealing with hearts that are literally developing and adapting in real time.
So the normal values are always a moving target.
Always. For example, the whole circulatory system, it maintains right ventricular dominance early in life. And our standards for blood pressure, for heart rate, they have to account for age and size. You can't just use fixed adult values.
Recognizing that difference is probably the first step to mastering this field.
Yeah.
Okay, so let's start where every good workup begins, the history. You can often find the root cause just by taking a really careful maternal history, right?
Yeah.
Specifically those teratogenic exposures.
Oh, absolutely. And this is pure recall gold for any exam. You have to lock in 3 key drug associations.
Okay.
So if a mother was on lithium, the red flag in your brain has to immediately go up for Ebstein's anomaly.
Got it. Lithium, Epstein's.
Then you have exposure to retinoic acid that's strongly linked to conotruncal anomaly.
Linked like truncus arteriosus.
Exactly. And then the third big one, if the mother needed warfarin during pregnancy, you have to worry about fetal warfarin syndrome.
And that can present as, what, Tetralogy of Fallot or a VSD?
You got it. TOF and VSD are the big ones to watch for.
But it's not just medications, is it? The mother's own health status can give us huge clues.
100%. Think about systemic disease. Maternal diabetes, for instance, significantly increases the risk for CHD.
Mostly transposition of the great arteries, TGA.
TGA is a big
Right.
one. Also VSD and PDA. And it raises the risk of cardiomyopathy. Then separately, if there's any maternal history of, say, a connective tissue disorder like lupus.
Then you're thinking congenital heart block.
Precisely. It's due to that transplacental antibody transfer.
Okay, so moving from history to the physical exam. What are the quick telltale signs that a child is struggling with heart disease?
Well, any kind of chronic cardiac distress, whether it's heart failure or cyanosis, it almost always shows up as poor weight gain, failure to thrive.
Weight is more affected than height, usually.
Much more. And then when you put your hands on the chest, if you feel a hyperactive precordium, that bounding feeling,
You should immediately be thinking volume overload.
immediately. It's classic for a large left-to-right shunt or maybe significant valve regurgitation.
And what about auscultation? Specifically, the location of a thrill, that buzzing you can feel. That can be almost diagnostic on its own.
It gives you powerful, immediate information, but you have to know your landmark. So a thrill way up high at the upper left sternal border, or ULSB.
That screams pulmonary stenosis.
Yep. Now, if that thrill shifts over to the upper right sternal border, the URSB,
Then you're thinking aortic stenosis.
perfect. And the most common spot, the lower left sternal border, the LLSB, that's your classic ventricular septal defect.
Those are the landmarks you just have to burn into your memory.
Absolutely.
Okay, that really sets the clinical stage. Now let's switch gears to the electrical side, the pediatric ECG. This is where adult parameters can really leave you astray. Tell us about that early RV dominance.
This is such a fundamental concept. In utero, the fetus relies heavily on the right ventricle to push blood, to the whole systemic circulation through the ductus arteriosus.
So the ECG is naturally dominated by right-sided forces.
Exactly. That right ventricular dominance means a QRS axis that would be frankly wildly abnormal in an adult is perfectly fine in a neonate.
So what is the normal range for that QRS axis then?
In a neonate, let's say 1 week to 1 month old, the mean QRS axis is around plus 110 degrees. It can go all the way up to plus 180 and still be normal.
And that transition to the adult pattern with LV dominance, that doesn't happen until they're 3 or 4 years old.
That's right. It takes a few years to stabilize. And speaking of the QRS, we also have to watch the duration. A prolonged QRS interval for that age is a big red flag for a ventricular conduction disturbance.
Like a bundle branch block.
And then there's the QTC interval, which is, a potential arrhythmia time bomb.
What are the bounds we need to watch for there?
Well, it varies a bit with age, but a good rule of thumb is that the upper limit of normal in the first week of life is about 0.47 seconds.
And on the flip side, if it's extremely short,
If you see extreme shortness, you have to consider the lethal short QT syndrome. That's defined by a QTC of 300 milliseconds or less. It's a familial cause of sudden cardiac death.
okay, let's move from electricity to mechanics, blood pressure. Our sources point out a pretty major historical error here. What's the old practice that's been debunked?
The old way of picking a BP cuff based on the length of the arm, that's just scientifically unsound. It's been totally replaced.
So what's the standard now?
Today, the gold standard for data comes from the San Antonio Children's Blood Pressure Study, or SAC-BPS. It gives you these incredibly detailed percentile-based norms by age, sex, and height.
But the really crucial point for practice is the method, right? Auscultatory versus oscillometric. They aren't the same.
Not at all. And this is where a lot of clinical mistakes happen. You cannot use the same reference table for both methods. The automated oscillometric devices, like a Dynamat,
They read higher.
significantly higher. Systolic is often about 10 millimilli-Hg higher, and diastolic may be 5 millimilli-Hg higher than what you'd get with a stethoscope.
So if you use the wrong table, you'll be overdiagnosing hypertension left and right.
Exactly. You have to match the table to the technique.
Okay, last of the tools, imaging. Let's start with the echo. For LV function, what's the go-to index?
We usually rely on fractional shortening, or FS. It's very reproducible. A mean normal value is around 36%. But the real intellectual challenge comes with Doppler.
And the simplified Bernoulli equation.
Right. P1, P2 equals 4 Vmax 2. It's this amazing equation that lets us estimate the pressure gradient across a blockage, like a stenotic valve, just from the velocity.
But there's a huge caveat, a trap that practitioners fall into involving V1, the proximal velocity. Why is it so important?
Because the simplified equation just assumes V1 is basically 0, which is usually fine.
Oh.
But in really high flow states, like severe aortic stenosis or a bad coarctation, that velocity before the blockage, V1, can be over 1.5 meters per second.
And if you ignore it?
You will significantly overestimate the pressure drop. You'll make the stenosis look much worse than it is.
So you have to use the full equation in those cases.
You must. Or you risk misclassifying severity and, maybe even rushing a patient to an intervention they don't need yet.
And if the echo just isn't giving you the full picture.
Then we move to advanced imaging. MRI is king for quantifying ventricular size and function in detail, and CT is fantastic for looking at the vessels outside the heart, the aortic arch, the coronaries, places where echo windows can be tough.
All right, let's dive into the pathology, starting with the most common CHD of them all, the ventricular septal defect, or VSD.
VSDs make up about 15 to 20% of all congenital defects. The key is that the consequences all depend on the size of that shunt.
So smaller shunt mainly stresses the left side of the heart.
Right. A small or moderate left-to-right shunt is going to cause volume overload in the left atrium and left ventricle. But if that defect is really large...
Then the right side gets hit too.
Exactly. The right ventricle ends up dealing with both volume and pressure overload.
Next up, patent ductus arteriosus, PDA. This one has that classic finding everyone remembers from med school.
Yes, the textbook continuous machinery murmur. You hear it best up near the upper left sternal border.
But the real clinical impact is in the tiniest patients, isn't it?
Oh, it's enormous. In preemies under 1,200 grams, the incidence of a PDA that's actually causing problems can be as high as 80%. And that huge LR shunt floods the lungs with blood, causes pulmonary overcirculation, makes the lungs stiff, and it can make getting that baby off the ventilator almost impossible.
Now for the classic cyanotic lesion, Tetralogy of Fallot, TOF. Defined by its 4 components.
You have to know these 4 colds. You have the large VSD, you have the obstruction of the RV outflow tract,
The overriding aorta.
and the resulting RV hypertrophy. And the clinical presentation, whether the baby is blue or pink, it all hinges on one thing.
The degree of that RVOT obstruction.
That's it. Severe obstruction forces deoxygenated blood right to left through the VSD, and the baby is cyanotic. Mild obstruction lets blood shunt left to right, and the baby is initially acyanotic, a pink tet.
And on X-ray, the classic finding in a cyanotic patient.
The boot-shaped heart with decreased pulmonary vascular markings. It's a classic image.
Moving on to valvular disease, aortic stenosis. It often starts with a bicuspid aortic valve, right?
That's the most common cause, yeah. And we grade its severity with a Doppler gradient. Once you get over a 70 mmHg peak gradient, you're in severe territory.
And surgically, the preferred procedure is the Ross procedure. Why is that?
Because it's an elegant solution. You take the patient's own pulmonary valve and you autograft it into the aortic position.
So it can grow with the child.
Exactly. It offers long-term durability, it has growth potential, and, this is the big one, it eliminates the need for lifelong anticoagulation. A huge win over a mechanical valve.
Let's shift to acquired diseases now, starting with infective endocarditis.
Mm-hmm.
We need to know the likely culprits based on where the infection started.
Right, you have to track the path of the bug. If it's after a dental procedure, you should be thinking alpha hemolytic strep, like S. viridans.
And if it's after a GI or a GU procedure?
Then you suspect enterococci. Management really hinges on the modified Duke criteria. But what's crucial to know now is that prophylaxis has been dramatically scaled back.
It's only for super high-risk patients undergoing specific procedures.
Right, only for high-risk cardiac lesions during procedures that involve mucosal manipulation, like certain dental work. It's not for everyone anymore.
Okay, what about Kawasaki disease? Still the leading cause of acquired heart disease in kids.
It is. And it's a clinical diagnosis. You're looking for that fever for at least 5 days, plus 4 of the 5 classic criteria.
Conjunctivitis, changes in the hands and feet, the rash, the oral changes.
Like the strawberry tongue, cracked lips, and the cervical lymphadenopathy. But the reason we care so much, the risk we're trying to prevent, is the development of a coronary artery aneurysm.
Which happens in, what, 15 to 25% of untreated cases?
That's the number. And if an aneurysm develops, the long-term management implications are just huge, especially for those in the highest risk levels, IV or V.
They often need lifelong therapy.
Often. We're talking dual therapy-dose aspirin plus an anticoagulant like warfarin. And because of the fragile vessels and the bleeding risk,
Contact sports are off the table.
strictly limited or, more often, prohibited.
And that brings us to the most tragic link between cardiology and athletics, hypertrophic cardiomyopathy, or HCM.
Yeah, the most common cause of sudden cardiac death in teens and young athletes, it's a genetic disease that causes this massive, often asymmetric thickening of the ventricle.
And the mechanism of obstruction is that systolic anterior motion of the mitral valve, the SAM.
Right, the thickened septum basically sucks the leaflet into the outflow stream during systole. And what's so high yield about this is that the obstruction is dynamic. It changes.
How does that work clinically? What makes it worse?
The obstruction worsens anytime you reduce the volume in the left ventricle.
So dehydration, for example.
Dehydration, giving vasodilators, or positive inotropes, it all makes the obstruction worse.
Which is why patients with unexplained syncope or those with extreme LV wall thickness, say 30 millimeters or more, are considered high risk.
And they automatically become candidates for an implantable cardioverter defibrillator, an ICD.
Let's quickly run through some electrophysiology essentials. How do we identify a rhythm as being true sinus rhythm?
3 things. There must be a P wave. The PR interval has to be normal for that age. And crucially, the P wave axis has to be between 0 and plus 90 degrees.
Which means the P wave is upright in lead 2 and inverted in AVR.
That's the key. And remember, while kids' heart rates are faster, true sinus tach usually tops out below 200 beats per minute in an infant.
And when we jump to SVT,
the most common mechanism is AV reentrant tachycardia. And clinically, you have to distinguish the 2 types by looking at the QRS width.
orthodromic versus antidromic?
Exactly. Orthodromic uses the normal AV node pathway, so you get a narrow QRS. Antidromic uses the accessory pathway in reverse, so you get a widened QRS.
And treatment starts with vagal maneuvers, then adenosine.
Rapid fee bolus of adenosine.
Okay, for the life-threatening stuff. Ventricular tachycardia and long QT syndrome.
VT is just defined as 3 or more PVCs in a row, usually running between 120 and 200 beats per minute. LQTS is the genetic setup that predisposes you to a specific type of VT, torsades de pointe.
And the diagnosis relies on that QTC prolongation, using the Schwartz criteria point system.
Right. And management is mainly high-dose beta blockers and often an ICD, depending on the patient's specific risk profile.
Finally, let's talk about prevention. Our sources make a really sobering point about when atherosclerosis actually begins.
It is a pediatric disease. We have to stop thinking of it as an adult problem. Autopsy data has shown pretty definitively that the earliest lesion, the fatty streak, shows up by age 5 to 8.
Wow. By 8 years old.
And the more advanced fibrous plaque is already there in the coronary arteries by the late teens.
That really drives home why preventative cardiology in kids is so important.
It's non-negotiable.
So with that early onset, how should we be screening kids for dyslipidemia?
The best tool is non-HDL cholesterol. It's just total cholesterol minus HDL-C, and it captures all the bad atherogenic lipoproteins in one number.
And what about treatment? Statins.
Lifestyle is always first. But yes, we do use statins, though generally only for kids who are 10 years or older with really high LDL, say over 190, or maybe a bit lower, but with other compounding risk factors.
And for managing high blood pressure in kids?
The first-line drugs for long-term control are often ACE inhibitors, ARBs, or calcium channel blockers, especially if the patient also has diabetes or kidney disease.
Beta blockers are more for specific situations.
Right, they're reserved for things like concurrent migraines or a hyperdynamic state, and you have to be careful with them in kids with asthma or insulin-dependent diabetes.
Wow. That was an incredibly dense, high-yield journey through the essential tools, pathologies, and management principles in pediatric cardiology.
I think the real value in mastering all this is being able to connect the dots, understanding why a teratogenic exposure matters when you're looking at a rhythm strip, or why a kid's hydration status can determine if their HCM is bad enough to make them pass out.
And we want you, the learner, to be able to make those same critical links. So we'll leave you with a final clinical challenge question to pull it all together.
Okay, here's your scenario. A 16-year-old competitive swimmer presents to the ER. He had an episode of syncope while getting out of the pool after a really strenuous practice. His exam is unremarkable, but his dad mentions that the boy's 35-year-old cousin died suddenly during exercise about 10 years ago. Based on what we've covered, name 3 specific high-risk cardiac conditions that you must definitively rule out in this athlete, and describe the single most essential diagnostic study you'd need for each one.
Think about those genetic syndromes and the dynamic issues that can cause sudden death in athletes. We'll leave you to draw the connections. Thank you for joining us for this deep dive.